Chapter 13, Care of Patients with Disorders of the Upper Respiratory System. These are your chapter objectives. These are your clinical objectives. The upper respiratory tract includes the nose and sinuses, mouth, pharynx, and larynx above the vocal cords. The larynx below the vocal cords and the trachea are considered lower airway structures, but these are frequently involved in upper airway issues. Upper respiratory infections include viral and bacterial infections resulting in the cold, flu, pharyngitis, rhinosinusitis, epiglottitis, laryngotracheitis, and pertussis. Trauma and allergies will also cause nose and sinus disorders. The common cold, known as acute viral rhinitis, is an inflammation of the nose and the upper respiratory tract. Other names for a cold may include nasopharyngitis, rhinopharyngitis, acute coryza, and the head cold. It is the most prevalent infectious disease among individuals of all ages. Chill, fatigue, physical or emotional stress, a compromised immune system, or inflammation caused by allergic rhinitis will make an individual more susceptible to contracting an upper respiratory virus. As nurses, we advise the patient to stay indoors, preferably in bed or resting, especially during the first few days of the illness. They should intake their fluids should be increased. Fruit juices are recommended, especially citrus, because of their vitamin C content. And mild, non-prescription analgesics can help relieve the muscle aches and headache of a cold. The use of zinc to decrease the recovery time from a cold is recommended by many healthcare providers. A major goal when we're caring for patients that have a common cold is the prevention of a secondary bacterial infection. Individuals with a cold should avoid contact with others to avoid contracting a bacterial infection or giving them their viral infection. There is no cure for the common cold. It is important to distinguish a cold from other upper respiratory infections that may be bacterial and may need antibiotic therapy, or that are conditions that in some patients may lead to more severe illnesses. The treatment of allergic rhinitis is symptomatic. The goal in the care of a common cold is the prevention of the secondary bacterial infection. The person with a common cold is contagious for about 3 days after their symptoms first appear. Aspirin should never be given to children under the age of 18 years of age. This is due to the occurrence of Reye's syndrome. Adults that take anticoagulants or non-steroidal anti-inflammatories should not be advised to take aspirin because this will prolong their clotting time. Sinusitis is an inflammation of the mucosal lining of the sinuses and can be caused by an infection or by allergies. Rhinosinusitis is the preferred term because the nasal mucosa is almost always inflamed along with the sinuses. Viral infections are the most common cause of rhinosinusitis. Sinusitis often occurs after a cold or other respiratory infections and during periods of uncontrolled allergic rhinitis. The nasal passages can be blocked by a deviated septum, which may occur congenitally by injury to the nose or even nasal polyps. Polyps may occur from repeated inflammation of the nasal mucosa, and these are tissue growths that obstruct an airway. People with a deviated nasal septum or allergy problems tend to have recurrent sinusitis. Symptoms will include tenderness over the sinuses, purulent drainage from the nose, nasal obstruction, and sometimes a non-productive cough. The upper teeth may also become painful. The treatment for sinusitis includes relieving pain, promoting sinus discharge, controlling bacterial infection, reducing inflammation, and the prevention of recurrence. As a nurse, we advocate rest, reducing stress, a balanced diet, and the control of allergies to help prevent recurrence of sinusitis. We also express to our patients that fluid intake should be increased. There is no scientific evidence for the common belief that dairy products increase the thickness of secretions or produce mucus. Epistaxis is a common occurrence and usually results from crusting, cracking, or irritation of the mucous membrane covering the front or the anterior nasal septum. Anterior bleeds are the most common at 90 to 95%. Blood loss is routinely minimal, but about 6% of nosebleeds will require medical attention. Any condition or medication that prolongs bleeding time or decreases the platelet count may predispose the individual to nosebleeds. Nosebleeds may also result from trauma, hypertension, and blood disorders such as leukemia. They are also common in boys during pubescence. Once bleeding stops, the patient should rest quietly for a few hours and be instructed to avoid bending over and not to blow their nose, pick at it, or rub it for 24 hours after the nosebleed has ceased. When your patient is having an active nosebleed, a nurse should instruct them to spit the blood into a basin or tissue rather than swallowing it. An accumulation of blood in the stomach will eventually cause nausea and vomiting, and the patient's cooperation will assist the nurse to assess the amount of bleeding and may help prevent an aspiration of blood. Patients that are on anticoagulants and antiplatelet therapies are at an increased risk of nasal bleeding, while a nasal cannula oxygen is administered for prolonged periods. Nasal cannula oxygen will cause drying of the nasal mucosa. Pharyngitis is an inflammation of the pharynx, usually called a sore throat. This may be caused by a virus, bacteria, or a fungus. Most cases are viral. Acute follicular pharyngitis, or the strep throat, is caused by beta hemolytic streptococcal infection. Fungal pharyngitis occurs with long-term use of antibiotics or inhaled corticosteroids, and in patients with immunosuppression, such as individuals that have HIV or AIDS, or even during cancer treatment. Laryngitis is an inflammation of the larynx with diminished voice or hoarseness, and this may occur if the infection progresses into the larynx. When inflammation extends to the epiglottis, epiglottitis may occur. This is more common in children. Epiglottitis can cause an acute airway obstruction and needs to be monitored closely. If swelling of the structures is present, dysphagia may occur. Discomfort when swallowing one's own saliva is common, but does not usually inhibit the ability to intake adequate fluids and nourishment. The usual course for uncomplicated pharyngitis or laryngitis is 3 to 10 days. The diagnosis of pharyngitis is confirmed by clinical signs and symptoms. A throat culture is often performed to confirm or rule out streptococcal infection. Chronic pharyngitis may require diagnostic procedures to determine the underlying cause and therapeutic measures, such as humidification or filtering of environmental air. Fungal pharyngitis is treated with an antifungal agent, but it may be more difficult to control in an individual that is immunocompromised. An infection with inflammation of the tonsils is usually caused by viruses, such as those causing the common cold. Group A Streptococcus is the most common organism causing the bacterial infections. Symptoms are somewhat similar to those of pharyngitis. Acute tonsillitis may occur repeatedly, especially in those who have a low resistance to infection. Tonsillitis that is caused by the Epstein-Barr virus is called glandular fever or infectious mononucleosis. Chronic tonsillitis usually produces an enlargement of tonsillar and adenoidal tissues. Chronic infection produces less dramatic symptoms than acute tonsillitis, but the patient's discomfort will still occur. A person with chronic tonsillitis and enlarged adenoids has frequent colds and appears to be in poor health. A throat culture is performed before treatment to check for the presence of streptococcus, which can cause rheumatic fever or glomerulonephritis if not treated appropriately. Surgery may be used to treat tonsillitis when it is recurrent or when the enlargement of the tonsils and adenoids obstructs airway. Surgery is considered if the patient has more than 6 episodes of streptococcal tonsillitis per year. Pre-op preparation of the patient involves administering preoperative medications as ordered, restricting the use of aspirin and other non-steroidal anti-inflammatory medications, and restricting the patient's diet for 6 to 8 hours before surgery. An elevation of temperature or any signs of a upper respiratory infection should be repeated before surgery because it may usually be postponed if these signs or symptoms are present. For post-op care, a nurse needs to be vigilant for signs of hemorrhage. Vital signs are checked frequently, and the patient is observed for frequent swallowing or clearing of the throat. These may indicate bleeding. Restlessness may be another clue to excessive bleeding. Sneezing, coughing, and vomiting can cause bleeding. An ice collar or an ice pack may be placed around the patient's neck to help reduce swelling and pain. A side-lying position when drowsy or a semi-Fowler's position when fully awake will help the patient maintain a patent airway. The post-operative diet routinely consists of cold or warm liquids, progressing to semi-solid foods for the first 24 hours. We want our patients to avoid any red foods so we can help in distinguishing between ingested food and blood. Citrus fruits, hot fluids, and rough foods should be avoided until the throat has completely healed. Straws are not to be used because sucking may cause bleeding. And as a nurse, we need to note that stools may be black due to the swallowing of blood. Laryngeal edema caused by the inflammation of an infection or an allergic reaction, a crush injury, or a foreign object or food that goes down the wrong airway rather than the esophagus may obstruct the airway. The nurse may also be required to oxygenate the patient using the resuscitation bag administer medications for rapid sequence intubation, or assist in making the equipment available to the clinician when they are performing an intubation. An unconscious adult or a child older than 1 year, the most common cause of airway obstruction for them is the tongue. An artificial airway may be orally or nasally inserted because it helps to keep the tongue in place. Obstructive sleep apnea is a condition in which during sleep the individual is making a breathing effort, but there is no or extremely limited airflow. Muscle relaxation at the back of the throat is the most common cause. This allows the tongue to fall back and block the airway. Daytime symptoms may include fatigue, morning headaches, and difficulty concentration. Physical examination of patients with obstructive sleep apnea typically reveal obesity, an enlarged neck circumference, and hypertension. Sleep studies should be performed to determine the severity of the condition. Those with mild apnea may be treated with conservative measures, such as weight loss, avoiding alcohol for 4 to 6 hours before bed, and sleep position modification. The first line of therapy for sleep apnea is nasal continuous positive airway pressure, or a CPAP, that is applied with nasal prongs. If that is unsuccessful, a bivalve positive airway pressure, or a BiPAP, may be tried with a face mask or a nasal mask. A nasal fracture will often result from sports injuries, motor vehicle accidents, or physical assault, and is the most common type of facial fracture. If the cartilage or the bone is not displaced, complications are unlikely and no treatment may be needed. The displacement of the cartilage or bone can interfere with airflow, cause deformity of the nose, and become a potential spot for infection. If the fracture is severe, rhinoplasty, which is surgical reconstruction of the nose, may be performed to improve the airflow and the cosmetic appearance. Nasal packing, internal and external splints or sutures may be used to stabilize the septum postoperatively. Which nursing intervention would be appropriate during the immediate postoperative period for a patient who has undergone rhinoplasty? The correct answer is number 1 and number 5. A clear association has been made between cigarette or cigar smoking and excessive use of alcohol and the development of laryngeal cancer. The lack of fruits and vegetables in the diet, gastroesophageal reflux disease, immunosuppression, and infection with human papillovirus or H. pylori have all been linked to increased incidence of cancer of the larynx. Exposure over long periods to environmental pollutions such as asbestos, paint fumes, or wood or coal dust has been shown to be associated with an increased risk. The most common malignant tumor of the larynx is squamous cell carcinoma. It grows from the mucous membrane lining the respiratory tract. Metastasis may occur to the lung. Outpatient treatment is common. Radiation alone is 85% effective in treating early cancer of the larynx. Chemotherapy may be the initial treatment in some cases of laryngeal cancer. Combinations of chemotherapy and radiation may also be used. These treatments are used to shrink the malignancy so that it may be surgically removed. The goal is to preserve as much function as possible. Various signs of throat cancer are known to be common. Hoarseness that lasts, a sore throat that persists, pain in or around the ear, difficulty swallowing, maybe blood in the phlegm, or lumps or knots on the neck that indicate enlarged surgical lymph nodes. Endotracheal tubes are used for short-term respiratory support, such as for the immediate relief of airway obstructions, for patients with decreased level of consciousness due to trauma, during anesthesia, or even for a few days postoperatively. With a tracheostomy, there is no connection between the nose and the mouth and the lower respiratory system. When a patient is expected to need an artificial airway for an extended period, a tracheostomy is preferred over prolonged endotracheal intubation. A tracheostomy is routinely considered after 1 to 3 weeks of intubation. Tracheostomies are used to help assist ventilation, to assist in suctioning secretions in the air passages, and to prevent oral aspiration of gastric secretions. The patient's spouse asks, "What is the purpose of the tracheostomy?" Which comment will demonstrate the nursing knowledge regarding the procedure? The answer is 1, 3, 4, and 5. Immediate postoperative care focuses on maintaining a patent airway and observing for hemorrhage. During the first 24 hours, the nurse needs to monitor the patient continuously for signs of respiratory distress. If the patient is unable to cough to remove secretions and drainage, tracheal suctioning is necessary. If the lumen is not kept open, the patient will suffocate. Suctioning is done with strict sterile technique to prevent infection in the lungs. The lungs should always be auscultated before suctioning to assess the need, and afterwards to verify that the procedure has successfully cleared the airways. Psychological support of the tracheostomy for the patient and family is essential. The patient must learn to breathe in a totally different way, and they cannot speak or call out for help. The laryngectomy patient needs to be provided with a means of communication. Think about a pad and pencil, a dry erase board, or an electronic device. The proper rehabilitation for these individuals is important in the acceptance of surgery and its consequences. The speech therapist will help the patient master a new form of speech. Many people can learn esophageal speech. First, they master the art of swallowing air and then moving it forcibly back up through the esophagus. Then they will learn to coordinate lip and tongue movements with the sound produced by the air passing over the vibrating folds of the esophagus.